Okay, good morning, everyone. I think we'll go ahead and get started to make the best use of this time. Welcome to this session, Design as Preventative Care, a call to action. We're very excited to have 4 panelists with us to share their expertise today. I'm Catherine Joseph, I'm an architect. I'm joined by my colleague, Cathy Mph, who will be moderating the panel, and our panelists, Cynthia De La Rosa, Mac Levine, Dr. Yasmin Mia, and Sarah Ruel-Bergeron. We're excited to have gathered this group. We're going to begin with a short presentation to provide some context, and then we'll move into a moderated conversation with the panelists, and we'll curate some questions from the audience as well. So as they're speaking, if you share questions, we'll curate from the chat box. The work that led to this panel began with the 2019-2020 Forefront Fellows Program facilitated by the Urban Design Forum. The first research phase of the fellowship culminated in the Turning the Heat report, which is a collection of suggested strategies for addressing the problem of heat vulnerability in New York City. The report was a collaboration with the Mayor's Office of Resiliency and encompasses the work of 25 Forefront Fellows. And we're going to put a link to the report in the chat box. During the second research phase, we formed an interdisciplinary group of 7 fellows, of which Cathy and I were a part, to further examine the interaction of health and the built environment. What brought our group together was a common interest in public health and a recognition of large gaps in responsibility with respect to public health in each of our professions. Our work culminated in a resource gazette. I'm going to present a very abridged summary of that work, and we'll put a link to the digital version of the gazette in the chat box as well. When we began this work in May of 2019, we had no idea that public health was going to dominate our day-to-day lives for ourselves and everyone else in the coming year. But the current situation with coronavirus has reinforced how entangled public health is with the design and planning of our built spaces. The pandemic has revealed the challenges associated with addressing chronic health risk when facing acute health emergencies. What has also been widely recognized is that the communities previously identified as experiencing increased risk of heat vulnerability are the same ones who have experienced higher rates of COVID-19. While the work we're about to share is specifically related to climate risk and health, it's impossible to ignore our current context. Oops. Sorry. When we talk about climate resilience, we've most often heard about coastal resilience, rising sea levels, storm surges, and flooding from tropical storms. But climate risk encompasses much more, and the built environment can play a role in facilitating or preventing increased risk. Extreme heat events in particular cause serious and sometimes fatal health problems. In the United States, heat events led to more weather-related fatalities than any other climate event over the past 30 years. From 1999 to 2010, exposure to extreme heat led to 7,415 deaths, an average of more than 600 premature lives lost per year. While these numbers in no way compare with the magnitude of loss we're facing with the coronavirus pandemic, extreme heat events are becoming a chronic health problem globally, but especially in New York City. The associated annual costs of healthcare and lives lost due to extreme heat events are estimated at more than $4.4 billion. Imagine if that funding was used for prevention instead. What these numbers don't reflect are the conditions that are also exacerbated by extreme heat, including cardiovascular, respiratory, or renal illnesses. Anyone with pre-existing conditions such as multiple sclerosis or asthma are also vulnerable. Knowing that climate change is at the root of these heat events, we're arguing that in order to achieve climate justice, we must pursue equitable health outcomes for individuals. It's tempting to separate the risks of climate change on the built environment from the risks posed to the individual body. But we know that although these problems occur at different scales, they're inextricably tied. Focusing on health, in particular centering equitable health outcomes, identifies a goal that can address a variety of issues. When we speak of someone's personal health, most people think of medical care and genetics, but we often neglect social circumstance in the built environment, which account for approximately 31% of an individual's health. If we're to prevent the unnecessary loss of life due to heat events, we must include the design of the built environment in our response. Our approach has been to identify gaps in response or in protocol that hinder a robust response to climate and built environment health concerns. expanding existing planning and design processes to include proactive health criteria can facilitate immediate and long-term solutions that address climate-related health risks. For the purposes of illustrating this approach today, from the perspective of an individual, we'll highlight a few issues and solutions related to respiratory illness. A person's health is greatly affected by the built environment, particularly their immediate living environment. This is especially true when exterior allergens and climate events are allowed to permeate into the home. Heat and moisture that move freely through aging and poorly maintained building envelopes leave residents exposed to climate events. Renovation and retrofit at the scale of an entire building can be difficult to prescribe and are typically very capital-intensive projects. Heat waves are prolonged by the built environment and persist long beyond the end of the extreme weather event. Poor air quality is exacerbated by extreme temperatures. All of these adverse effects are known, but there's a disconnect between treating the health symptoms of extreme climate events and creating solutions for the root problem. Diagnosing and treating a person's apartment requires an expansion of the physician's role in overseeing the built environment and an expanded definition of preventative care. Insurance coverage of tenant-attached solutions helps facilitate the tenant's ability to maintain the health quality of the space they live in, particularly during extreme climate events. At the building scale, treatment of health risks that affect an entire building, like building systems and facade quality, can be layered into existing inspection processes, such as adding a health checklist to the facade inspection safety program. Recognizing the work already being done by community-based organizations and tapping into existing community networks can empower neighborhoods to implement solutions that reduce the heat island effect and address the disproportionate burden of infrastructure, hardscape, and lack of tree cover that affects some neighborhoods. By 2065, 180 million Americans will experience an average of more than 30 days with a heat index above 105 degrees Fahrenheit. That's about 60% of the population of the contiguous United States. We know that the built environment is a significant social determinant of health, and this influence is already exacerbated by climate change. Preventative care measures must be applied to the design of the built environment immediately and in the long term to protect New York City residents. But where do we start? This effort will take many people from many disciplines, but ultimately requires leadership and policy change. Advocating for an expanded definition of preventative care that includes the built environment will guide health and building professionals towards productive collaborations. Utilizing existing safety inspections and protocols, but expanding the scope to include climate health resilience and investing in community scale mitigation efforts are direct and achievable milestones towards design as preventative care. The current pandemic requires that we be more facile in our response, shifting our balance of long-term and short-term solutions to chronic climate issues while ensuring immediate health issues are addressed. While the pandemic and climate-related health risks have a different immediacy and scale of effect, they aren't separate issues, and we must not treat them as such. And now I'm going to pass the microphone to my colleague, Kathy Mph, and I invite the panelists well, you're already on screen, but to unmute your microphones and join us for the moderated conversation.
Okay, thank you, Catherine. As mentioned, we'll be now moving into the moderated conversation with our wonderful panelists. And the audience will have an opportunity for a Q&A towards the end. So please post any questions in the chat. If any questions can't be answered now, we'll do our best to get back to you after the session. So now, without further ado, I'm excited to be introducing our 4 speakers. So first up, we have Cynthia De La Rosa. Cynthia is a project manager supporting Hester Street's public health, resiliency, and community engagement projects across New York City and Puerto Rico. She has over 10 years of public health and community engagement experience and is committed to working alongside communities of color to address health inequities and create opportunities where people can thrive. Next up, we have Mac Levine. In 2008, Executive Director Mac Levine Mph founded Concrete Safaris with 16 East Harlem children. She has since grown the organization to serve over 19,000 children, youth, and families through after-school programs, internships, and outdoor events designed by children for the community in gardens, on city streets, and in parks. Concrete Safari's vision is youth transforming the world starting in their own backyards. Next up is Dr. Yasmin Mph, who is the Program Director and Chief Medical Attending of the East Harlem Health Outreach Partnership, aka EHOP, which is a student-run, attending-directed free clinic for the uninsured at the Icahn School of Medicine at Mount Sinai. Founded in 2004 by Dr. Mph, EHOP is now an internationally renowned free clinic for the uninsured and serves as an exemplary model of both high-quality healthcare and educational innovation. Dr. Mph is also a home-based medical provider through the Visiting Doctors Program, a primary care program that services the needs of homebound adults debilitated by chronic illnesses. And finally, we also have Sarah Ruel Bergeron, who is the Executive Director of Archive Global, a not-for-profit that implements projects combating disease through interventions to the built environment in vulnerable communities worldwide. She is a licensed architect and currently pursuing a certificate in global health practice from Johns Hopkins University. So first off, I want to thank the four of you guys for joining us this morning for this discussion. I would like to start this conversation with a question for Dr. Mph. So how have extreme heat events affected the health of the patients you work with? And how has COVID exposed new vulnerabilities and new priorities in care within your patient population?
Thanks so much, Kathy, and thanks so much, Catherine, and everyone here. Please call me Yaz. I very rarely get called Dr. Mph except by my patients, so thank you so much. Kathy, as you summarized, I'm a physician at Mount Sinai that services mostly the uninsured as well as vulnerable homebound patients. And so a lot of my work is actually in the community on foot. And so I've been able to really engage in public housing, and I see things firsthand because of my ability to actually make house calls, which is pretty much most of what I do. What we do know is that East Harlem was hit very hard by the COVID pandemic, and unfortunately is experiencing a second rise. It was certainly the summer months were a little bit of a relief, only in the sense that people could get outside, because for most of March and April and May, people were stuck inside, really couldn't leave their housing abodes, like really could not get to the store, could not get to work. Because COVID had disproportionately affected our patients, many of them actually were left with pretty serious respiratory illnesses that actually made them more susceptible to heat vulnerability or heat-related illness. So asthma, actually, which is fairly prevalent in East Harlem, was actually a far more significant problem. We found that many more of our patients were actually having respiratory exacerbations of their illnesses, whether it was asthma or COPD or emphysema. Many of our patients actually had out of control blood pressures, but also were susceptible to severe dehydration. And so we would, we were able to control blood pressures quite well, but we found that on normal regimens of blood pressure medications that they were becoming more and more susceptible to dehydration because of heat. In general, New York City did a fantastic job at taming the virus over the summer. As a result, many of our patients, about a significant portion of our patients actually died of COVID-related illnesses, particularly in my homebound population, not necessarily in my free clinic population. Heat really, the complexity or the interface between heat and COVID really became much more apparent in sort of the after effects of COVID, and because many of these patients actually did suffer sort of long-term illness. So it was kind of interesting because COVID really hit far before the heat wave actually hit in New York City. What made it complex, though, and really when you just think about just even apart from COVID, because I think what COVID really did was sort of unroof a lot of the inequities in our healthcare system just in general, and in particular for East Harlem, because East Harlem is just so susceptible to heat in general because of the landscape, right? Very few trees. There is a pretty excessive level of pollution. And as a result, the air quality is almost always quite poor in East Harlem. And so for those with respiratory related illnesses, or I should say respiratory illnesses or renal effects of COVID, it was that much worse during the summer. And so, it is certainly COVID, again, just sort of exposed all of the vulnerabilities. But it was interesting how the interface really just sort of made these inequities that have actually always been smoldering. I mean, the environment in East Harlem has always been problematic. It just made it so much more apparent. But I'll just sort of stop there just because I'm sure other people have other comments, and I mean, so many of us work in that environment. But yeah, I don't know if that answers your question well.
Yeah, definitely. Thank you, Yaz. I think, we'll just continue on to the next scale, because I think that would really create a fuller picture of the situation. So my next question goes to Mac, who works more at connecting the gap between the youth and the built environment in East Harlem. So my question is, how does Concrete Safaris educate youth participants about the built environment and explore their relationships to it? And can you describe how the recent rise of what you called the accidental volunteer has shifted the way Concrete Safaris engages with the East Harlem community? Oh, Mac, I think you're muted.
Hello, how are you? There's always something. Yeah, so first of all, I'd like to say thank you for everyone being so open to be able to discuss these issues, which are so important, particularly during a pandemic. We did see that parents in particular did not want their children outside, even if the children may have wanted to go outside. Other children were afraid to go outside, and they didn't want to get their families sick, particularly because so many of our families are, 8 to 13 people living in one apartment. And so as we look at educating kids, we're thinking, how does the parents feel about the kid being outside? And in East Harlem, now it's a pandemic, but even before that, people are reacting to gun violence. People are reacting to not having anyone to take their kid home if there's people working multiple jobs in the house. So first, does the kid have the curiosity to be outside? And does the parent feel comfortable with the kid being outside? And then we basically offer two different points of access. So we're looking at soft and hard skills. So does the child learn to be a good citizen? Can they communicate well? How do they interact with their community? How do they build advocacy skills? And then simultaneously, we provide a bicycle. We provide raincoats, winter coats, boots, anything that might be a barrier in East Harlem to getting a child outside. It can't be, oh, I don't have this, I don't have that. You don't have that? Okay, we'll make a list and we'll find it for you and you will get outside. There's no excuse. And then we basically have sessions on those various skills. And the kids learn how to make a speech. They learn how to ask for what they want. and need. They learn to survey the community to find out what the community needs. And then they take all that research and they use it to work with government officials and community board to get access to public space. So in our case, we're talking about access to open space in the public housing projects where they live, and then also to open streets. So to be able to shut down streets, to turn them into obstacle races, active living fairs, and we're able to have a small amount of people advocating for a larger community to be able to play outside, so that thousands of people can get outside because of the skills that this small group learns. And then once they learn those skills, then they can build on them. So they can now stay with us from age 7 to 24. So by the time that you're getting into age 14, then we can hire you. Then we could teach you what is it like to be able to work, to learn how to develop professional skills in those areas, so that when you come out at age 24, then you're able to put concrete safaris on your resume, and then people say, oh wow, that person must know these number of skills. And so then people want someone who has worked with us to work for them, because they understand that there's a certain level of quality coming out. But I think overall, the main thing, we're not trying to make everyone a gardener or everyone a racer, right? We're trying to provide and prepare kids with enough skills that they can go out into the world and be successful citizens, whatever that means to them. It doesn't mean the same thing for me as it may mean for them. And it's about meeting people where they are from the start of talking to your parents at whatever age that you come into our programs. And the second thing is, when we talk about volunteers, what we've seen is that if people were working multiple jobs before and now they're not allowed to go to that job, maybe they're working from home or they are unemployed, then they're for the first time seeing what does it look like when gardeners are outside their window gardening in spaces that they never saw before because they were not physically present. And we've had people put bags out the window, with rope, and rope down water so that people can drink water. That's a form of volunteerism, okay? That's not, I'm gonna come every day at 6 o'clock, okay? We've had people come every day at 7 o'clock when they know no one is there because they wanna garden in privacy or secrecy. We've also had people form committees, a little garden task force, okay, at each of our sites, where they are governing, they are texting, they are writing to each other, they are helping with supplies to grow food. And each person that's growing food is representing between, 3 and who knows how many people in their house. I've heard as many as 8 or 10 for the gardeners, and specifically. So then people of all ages are benefiting from the food that they're growing all summer. And we've been able to provide them with the tools that they need and the transplants and the space, which obviously is a hot commodity. And then we've also seen virtual volunteerism spike. There are people who want to do career readiness workshops, or they want to help out with back-end stuff for our office. And so it's a different kind of volunteer, maybe someone who is feeling the pangs of needing to leave their home without leaving their home. Or I think there's also like a sense of guilt, for people who've left the city or who haven't been active participants in city life to be able to serve without physically being here. And I think there's also like an awareness of privilege. So I am privileged enough to be able to leave, or I am privileged enough to never have to leave my house and to only get takeout and to, whatever those aspects may be. And they're able to contribute from their home and the safety and security of their home and deliver services that we really do need. So in that way, we have been able to serve more kids inside.
Macri, I'm just curious, Kathy, do you mind if I say something, just because, what I found is actually a lot of our patients were so afraid to go out, particularly if they had chronic medical illnesses, that they would actually block their kids from actually going out. And so you found, certainly in the summer, we found tons of kids in the apartments, locked in, very little airflow. I mean, it was sort of like a hotbed for badness, just sort of like psychologically as well as physically. And yet there was such a grave fear of children actually going outside to play and participate, because many of, certainly, you know, my patients had a lot of chronic medical illnesses, particularly my elderly patients who live with grandkids and great grandkids. They wouldn't let them out. And so it was, I'm just curious like how you encourage that, or like how you work through that.
Well, I think it's a balance. Like, we had our open streets, and the parent coordinator next to the open street sent out the blast to everybody with the emails, and the response was, what the hell are they doing? Our kids are not going outside. Okay. And then we had other folks where it was like literally the first time they were allowing their entire family to go outside onto a street. We had a man, I mean, I don't know how old he was, maybe 75. He just stood there holding his cane, staring at the sky, because he had not left his house in so long he couldn't remember what clouds look like in that way. We had children playing outside. I never have seen, I mean, I work in outdoor play. I have never seen smiles so big as someone, I'm going to cry. I mean, as someone who has not seen the outdoors except through their window screen, you know, if they even are lucky enough to have a screen, to actually physically be playing outside. And it's a group of 2 or 5 of the family that may go outside all at once, even toddlers coming outside who haven't been. And so I think when a community like East Harlem that has experienced so much trauma on a regular basis is then asked to go outside and experience more trauma, more death, you know, more people who can't even pay for the funerals. So it's like they don't want their kid going outside because they can't afford for everybody to die in their house physically, meaning the act of spending money, okay, in addition to obviously emotional relationships with the people they live with. And so I don't blame them for not wanting their kid to go outside. I don't blame them, but you know, it's like, then you have the opposite end of kids who can't be indoors because they're being abused, okay? And then they just don't have masks. They're standing on corners, and it's like people are different groups. Police, community advocates are trying to just hand them masks so that they can be safer. And it's like you've got these opposite ends of the spectrum where you need to provide basketball, you need to provide other types of activities that are going to keep older youth engaged without forcing them to go back into their house for who knows what type of abuse may be happening. And that has been a really challenging balance for us. And I think for the whole entire community. It's all people are talking about, as you probably are aware. You know, they're not thinking about climate change. They're just thinking about, how do I save my ass from getting whooped today? And so those are serious things that we are working on, I guess, collectively, all of us.
And if I may add, you know, communities like East Harlem are thinking about surviving the day-to-day, right? And so when we talk about public safety, when we talk about community safety, community well-being, that's at the forefront of what they're thinking. They're not thinking about climate change in like this big, you know, the way we are privileged right now to kind of think about climate change, how it impacts the planet, how it impacts the city. They're thinking about the microclimate, the climate in, you know, in their neighborhood. So kind of what Mac was just depicting right now, where you have teens on the corner not knowing what to do, maybe not being able to afford masks, maybe not even wearing a mask, and kind of fighting for their lives. Just as much as you have older adults kind of homebound, like as Yaz kind of walked us through today. So I just wanted to like name that in East Harlem, it's a dynamic neighborhood that has experienced so much trauma, and at the same time they're resilient and they're ready, willing, and able to overcome their challenges. But so climate change in their context might mean something very, very different as much as what we're talking about today.
So Cynthia, continuing along looking at the broader picture at East Harlem at a wider scale, can you talk more about the East Harlem Healthy Neighborhoods Initiative and the process of integrating public health into planning recommendations, and if you have any thoughts on best practice planners, public health officials, and designers are amplifying and representing the voices of the community in their work?
Sure. I'll talk about the East Harlem Healthy Neighborhoods Initiative very briefly. It was an initiative that was spearheaded by the health department at the time and supported by the New York State Health Foundation. And the four kind of focus areas were increasing access to fresh and affordable foods, increasing access to the built environment, linking residents to services, and bolstering economic opportunities. And those were like the four pillars of the initiative. And at the same time, East Harlem was going through a rezoning process. So what better way to kind of plug in to what all of these community charrettes and visioning sessions that were happening, you know, with the different community boards and community-based organizations at the time, and thinking through how do we build, how to be proactive and build off of the recommendations that were kind of that were kicked over by residents, right? And out of the 225 or 250 recommendations, the health department was able to say, okay, well, how do we respond to 25 of them? And we had a pool of money to give to community-based organizations like Concrete Safaris, for example, to respond to some of in their ideas and say, we don't want you to reinvent the wheel. We want to support you. How do we in these four priority areas? If you're going to improve the built environment, what does that look like? What does that mean in a short period amount of time? And sometimes I think, you know, in hindsight, I think government agencies that have access to capital or access to money can be funneling these mini grants, whether it be $25,000 or $50,000, to small grassroots organizations and nonprofits like Concrete Safaris, for example, that are already doing the work and already kind of meeting people where they're at, already working with young people and also having an intergenerational approach. So I think to answer your question in terms of what planners can do, well, one is sometimes it behooves planners to take a step back and recognize that the community folks, the community residents are the true experts. They know the day-to-day how the neighborhood functions, what they need. And sometimes it's just taking an extra moment to listen and to work with them from beginning to end and facilitate that process, and not necessarily facilitate it in a top-down approach, which sometimes quite frankly, sometimes planners just kind of come in with a heavy hand and their ideas already pre-populated and meditated. I think what we want to be able to do is kind of flip the narrative on its head and say, recognize that the community, like East Harlem residents, are experts. They know what they want. They're already doing the work. They have been organizing, you know, moving things, shaking things since day one. And so as planners, they need to be able to recognize that. So I think one of the ways that we were able to do that the Healthy Neighborhoods Initiative was successful was because we went we facilitated a process in tandem with the rezoning that was happening. And we said, we're here to listen. We're here to kind of just build off of what the recommendations that already people are saying. And we don't want to reinvent the wheel, but at the same time, we're coming with some money to back it up. And I think that's one way that, for example, planners and city agencies at a macro level can help support the day-to-day operations that are happening in a neighborhood like East Harlem.
Yeah, and I would say, like, in terms of what Cynthia was saying, one group that has been excluded, and that is a growing group in East Harlem, are the undocumented. And so we have a large population and growing population of undocumented persons in East Harlem. If you look at the demographic of East Harlem, many more undocumented in East Harlem than we did about 10 years ago. And so it is, but they are quite fearful of engaging in these community conversations for obvious reasons, and particularly now. ICE has really become quite problematic in the way that they mimic the police. They knock down doors. Several of my patients have been detained. And so it is, I would say that in terms of community leaders and elected officials, as well as appointed officials who engage in these conversations, that they need to sort of find ways to collaborate with those who lack legal residency status, but are truly residents of East Harlem.
Mm-hmm. Okay. So yeah, this is a very important topic that we'll definitely come back to. But for the moment, I would like to ask Sarah for an architect's perspective and the role of the home. So Sarah, can you describe how the design of a single home can be a catalyst to improve a community's health outcomes? And what supplementary systems or mechanisms at a community scale do you think are necessary to support that?
Sure, thanks, Kathy, and thanks again for inviting me to the conversation. I come as an architect, but I'm also not working in East Harlem, so I'm a bit of an odd person out, but I'm hoping that we can still bring in an interesting perspective to kind of round out the discussion, because I do think that our communities do have some of these similar concerns. So again, I'm here representing Archive Global, which stands for Architecture for Health in Vulnerable Environments. We're designing mostly household interventions for better health outcomes worldwide with a three-pronged approach, which involves research, design and implementation, and education. So that means we're starting each project by researching and innovating designs at the intersection of health and the built environment. And we're building these targeted but replicable solutions by iteratively improving interventions according to our community's needs. We're delivering comprehensive education to create lasting, locally driven health improvements targeting women and children in our project area. So really we're looking at one basic right, housing, to deliver one basic need, which would be health. Before I dive into an example, which is what's kind of represented on the screen here, it's our project in Bangladesh, I do want to get back to the perspective of the architect that's coming into this discussion. So I think it's always important for us to remember, and an important starting point for this conversation overall, is that health really starts in the home. From the most basic starting point of deciding to seek care and knowing what the thresholds are for needing care. So like when you actually have to really go seek care because your life is in danger or your family's life is in danger, to preventative strategies like prioritizing hand washing at appropriate times, how to handle food preparation. These are all decisions that are being made at home, and they're all impacting health. To add complexity to the issue, culture impacts health decisions, and I think the, really diving into this East Harlem example is really useful in that sense, because we can pull that apart a little bit more, as do gender norms and family's economic status. So there's a really complex intersection of things that are happening in the household that are having an impact on health. But that's from one perspective. Then there's also the household itself. Is the household enabling health, or is it exacerbating disease? Is the design enabling adequate ventilation or keeping dampness in and creating mold? Are there enough rooms to sleep in? Is the household overcrowded? Are vermin infestations present? Is there adequate insulation in the walls? Are there screens keeping mosquitoes out? Do you have an air conditioner, and can you afford to run it? Each one of these questions really relates to an inhabitant and a family's health. So in this way, it's important to remember that the home, and this is what I kind of want to put forward, especially from a planner's perspective, is that the home is the smallest unit of measurement, and that communities are made up of homes. And so we have to keep that in mind when we're thinking of designing at a kind of larger scale, that we have to think of the household perspective. And I think that this conversation already has a really good job about talking about specific households, specific families, and the issues that they're having, but I just want to kind of really drive that point home. But also, to get cohesion throughout communities, health literacy are really necessary. Add as a kind of supplementary mechanism. An inadequate household is to living a healthy life, but so are inadequate behavioral practices. And to improve behavioral practices, you need to increase people's health literacy. So just jumping to an example to kind of try to put a little bit of meat on the bones from an international perspective. Archive Global has been working on this project in Bangladesh, and you can see some images of that here. And in our project community, most families there are living on dirt floors, so luckily that's not something that's quite as prevalent in the United States, but I wouldn't say it's non-existent. And these floors are very, very difficult to clean. So animals and vermin walk all over them, coming from polluted water sources, from the latrine, or from an open defecation site. People can track things in on their shoes. And in Bangladesh specifically, people really spend a lot of time on the floor. They socialize on the floor. You can see in the bottom right picture, people are number 5, I guess. People are having a community meeting that's happening on the floor. And we also have children under 5 who are spending a lot of time, not only everything in their mouths. And so that becomes really problematic if your floors is really dirty and difficult to clean and has to be kind of maintained all the time to uphold even a really minimum standard of cleanliness. So in this particular project area, we propose to replace dirt floors with concrete floors. Bangladesh has 700 rivers running through it, so ensuring that a floor could withstand flooding in heavy monsoon rains is critical. You can see in picture number 2, that is flooding that happened this summer. And it's hard to see, but you can see that people they like build these little bridges so that they can still get to their homes, and then they put all of their items, like their beds and stuff, they put them on stacked up bricks so that they can continue to live in this household in this kind of environment. So you have, mosquitoes breed in stagnant water. And so you can imagine that this is kind of exacerbating some other problems, but this is how people are kind of dealing with this. So we chose to replace the floors with concrete in this particular context because you have so many rains and flooding is so prominent. The monsoon seasons are really heavy. And we replaced nearly 300 floors in the community, which we know is really important because I mentioned we do surveys to understand people's health conditions before and after the intervention. So what are some of those health improvements? We have diarrheal disease is decreasing, respiratory infections are decreasing, skin irritations are decreasing, stress and anxiety are decreasing. And then we have social status and home value that is increasing. And so we're having a number of health co-benefits coming out of this one single intervention. I think that's really important also when we think about the household as a preventative strategy for health issues is where can we get the most out of a single dollar? Can we do one particular intervention that's going to create a ripple effect into a number of health outcomes? What does that mean for the family? People are sick less often, meaning they can go to work more days of the year. Children can attend school more regularly. And so over time, you're seeing some economic benefits within the family because they're just having less expenses and they're able to bring income in more regularly. But we really wouldn't get those impacts without the education modules that our local partner carries out, where families learn about how to maintain their new floors because it's the first time that they're getting concrete floors and have lived on these types of floors, but also proper sanitation and hygiene practices. And what we've heard from our local partner and from our families in this particular community in Bangladesh is as COVID hit, they started asking our local partner, did you guys know that this was coming? Because now we really understand how to wash our hands well, when to wash our hands. And this was a kind of added benefit that if you do the education modules correctly, they can really have a lasting impact. So I'll leave it there, but I'm just going to try to paint a kind of picture around how this is all one full loop.
Can I just chime off of that, because it's so relevant what Sarah's talking about, even though it's so relevant to East Harlem. Like when I go into these apartments, one of the things that I see, well, the first thing I see is that many of these apartment buildings, in particular tenement type buildings that many of our uninsured live in, but also our elderly who are insured, they don't have ramps, they don't have access points to the actual front door. The second thing is that the elevators are usually coated in motor oil to actually resist urination and graffiti. And so as a result, that becomes sort of, it harbors a lot of respiratory, or at least it's a prime place where respiratory illness can actually worsen. And then if you look at inside in the apartment buildings, so many of our, or I should say in the apartments themselves, many in particular of my uninsured patients actually do have mattresses on the ground. They do not have beds. They don't have any elevation. So the floor surface actually becomes sort of where they live, where most of the activity actually happens. And then the other place that needs far more attention are the bathrooms and the air conditioners, if they even have them. These are things like just in terms of, the built environment that I don't think that housing pays enough attention to. Certainly the bathrooms are almost always filled with mold because of poor ventilation systems. And then the air conditioners, when they do have them, are never cleaned regularly. They often harbor quite a bit of mold. People don't know how to maintain them. And in many of these buildings, particularly NYCHA non, or those that are not owned or run by the New York City Housing Authority, they do become sort of dense with, the filters become dense with dust, and they're never cleaned out or maintained, which is a breeding ground for respiratory illness.
It's really important to note that inadequate housing is not something that's like out there in Bangladesh. And so when I was providing some examples, I am trying to, provide some examples, when I'm like inadequate ventilation, overcrowding. But these are all issues that we're hearing from the panelists that are really happening in East Harlem. They happen everywhere. Inadequate housing is present in every city, in every country. And so it really has to be addressed. And it's probably one of the more important preventative strategies for health. It is underrepresented, not well understood. We're trying to understand where the gaps in research are so that we can prove that there is a real link between these two, so that you can make a case for funding being directed in this direction. At the moment, I think it seems really obvious to us that housing and health are related, but there's not that much evidence there. And so people are able to brush it off and say, well, evidence isn't, I don't need to funnel money towards it. And so we need to really think about, and as people who are hopefully entering into this profession really understand that there's gaps there. And if we can design projects properly to be collecting the data, to be making the case for this, that's where I think we can have some policy change over time. I don't want to derail us too much, but I think it's a really good point, Yasmin, to say that this is really everywhere.
Yeah, thank you, Sarah. Yes, I think that's a very natural lead off to my next question, actually, which I would like to pose to everyone. So we're wondering, what opportunities do you see for more effective collaboration between health and built environment professionals, especially in service to the community?
I could start. So I guess I'll tell you what I've seen that hasn't worked, and my thoughts on what could work. East Harlem is like a very researched neighborhood, and the mega organizations in this neighborhood win multi-million-dollar grants to research and study and put out reports on how poor people are. And they go and make fill rooms with some food on a table to attract people, and the usual folks show up to those meetings and fill out a bunch of forms and surveys and charts and post-it notes on a board and a wall and lots of markers, and kids have a good time, yay. Okay, but is that reaching the general population? And the answer is no. If you can see Yaz's face, then you will know that it is not reaching the general population. There are people who would never be caught in a meeting like that because they don't even want to be seen in a meeting like that, for a variety of reasons, okay? They may not have status that would make them feel comfortable to be in those meetings. They may not feel like they're part of mainstream society of East Harlem. They may not, for whatever reason, want to be in the same room as police, if police are there guarding the room. And so if these groups are actually going to be representative of the people that they claim to serve in their multi-million-dollar reports, then they need to also change how they look at collaboration and change who they're speaking to in the community, because they're not actually reaching the people that need it most. And I think one thing that we talk about so much in many meetings, I think related to law enforcement, is, how do you reach the unreachables? Okay, you have to start with the people who are going to show up to the meeting. I think all of us understand that. Okay, but there must be like a next level. Okay, and I think the problem is that when you have outside researching, meaning I'm going to go around the neighborhood and I'm going to research, if you don't really look like the community, if you don't come from East Harlem, if you don't reflect anything that embodies people are just not going to talk to you, and they're not going to be real with you. So I think doing a better job of hiring from East Harlem and or whatever community you aim to serve, not having outsiders come in and then try to interpret what East Harlem is saying, okay? Because there isn't one person who speaks for all of East Harlem. And people who are on the outside don't really get that. That's an enormous problem. And I don't know, I could ramble on and on about this topic. I feel all of you could say something of value, so I'm gonna shut up.
Well, one of the things I think is really interesting, I completely agree, and I'll get to some of that, but one of the things that I think is really interesting is a lot of times in the international context, if you are an external party, then people start to listen and people start to talk to you. So there's, you know, I think that just points out understanding your context is so important, and the culture around sort of like aid and doing it appropriately. That doesn't mean that you don't go in with a local partner. It doesn't mean that you don't try to understand people's opinion fully, but there is, for the local partner, it's actually often really important for you to be visible so that there is more community buy-in, because you're usually bringing money that maybe the local partner doesn't have, for example. So it's just staying kind of different perspective, but making sure that you understand which side you're kind of coming from it and who the communities that you're going to be speaking to and how they respond best to these kind of conversations, I think is important. But I do think, to your point, collaborations across discipline, but also across like scales of organization is so critical. So, you know, we'll work with, you know, as a design firm, we'll work with public health professionals, or we'll work with, I'm not saying we're a design firm, but, you know, you might work across a bunch of different settings, but then you also need to work, you know, yes, sure, there's an important role for academia to play in this conversation, because they can gather data in a way that, again, can be like reported in a way that the scientific community will, you know, accept, and it'll start to have some policy impact. But that being completely separate from the smaller scale of the local nonprofits that are working with the community every single day. They know everybody's name. They are on the streets on a daily basis. They just know what is happening in that community. I think working in those, you know, both sort of horizontally and vertically, I think is really critical. And it's hard to get all the right stakeholders around the table, but making that effort from the very beginning so that you have all the right people at the table from the get-go, I think is critical to ensuring the success of any projects and following through. I mean, I think one of your big points is follow through.
Yeah, I guess to that point, I would say that follow through is one of the most important things. But I think even a step before that is being very intentional with your approach, especially with institutions, big institutions that are currently present in Mount Sinai or in low income communities of color, and kind of they tend to helicopter into a neighborhood and with an agenda and say, we want you, and then you incentivize them and you get some data, but there's no what's in it for the community. There's not a sense of getting people at the table, and or even the recognition that not even if you get people at the table, you will never get all the right people at the table, because historically, right, Black, brown, immigrants, even undocumented immigrants have been excluded from these conversations day in, day out. And the fact that it's 2020, we're still talking about communities being excluded from neighborhood decision-making, the neighborhood decision-making process is like, obviously we're not getting it right. So there are some ingredients to this that we're just not, we're missing the mark. All that to say is that we're missing the mark. And I think it's institutions, or it's even small grassroots organizations, the nonprofits that kind of need to hold these big institutions accountable and really knock at the table and saying, like, this is what we don't deserve this kind of treatment. These are our demands. This is what we need to do in order to work together and move forward as a collective. And I think that level of intentionality, it takes some time, and it takes the depth and breadth of those research projects kind of are actually in the hands of the institutions that really should have have community centered, this community centered approach, and sometimes that's not the case.
But I think
sorry.
No, go ahead. I was just going to point out the research thing, but go ahead.
No. I was going to I kind of chime Well, so to Sarah's point, one of the things that and to Cynthia's point, one of the things that I think does help hearing, from my perspective, is that I think organizations like mine that are in the community and have built a lot of trust in the community, we're not present at the table enough, right? So we're not at these community meetings, right? So myself, my colleagues who are home-based physicians and nurse practitioners, social workers, we're not at these community meetings enough. My students are making a lot more effort to be at these meetings, but I don't, and I think that may build more trust. If you also have people who are already trusted people sort of in the community now at these meetings, just as Sarah said, also these are, we are outsiders, but yet we're insiders in the sense that we've been working and we've been working in the community for so long. So we're respected and we're people who are sort of known. So, it does make me think that we should be at the table a lot more. It's just, I think there's a little bit of apathy on our part, to be honest. And I'm going to take ownership of that. I think there's a sort of a sense of, this is my discipline. Why do I need to sort of move out into other disciplines? I mean, I think a conversation like this is sort of emblematic of like an effort to do that, to cross over. I just don't think that we do it enough.
Well, and what I was going to point out is, Cynthia, something that really was interesting that you mentioned is that these were research projects. And I think that's a really important distinction. If it's a research project, it's not an implementation project. There is no plan to carry that research into implementation. And I think being really clear with the community about what they're getting involved in is huge. Because if we come in and say, okay, we're doing a research project, but you kind of gloss over that, and then you talk about, well, what are your issues? What are your problems? How can we resolve these? Like, even if I collect all of the information about how you think this can be resolved, I don't have any funding for the implementation side of it. So I'm only going to be collecting that data. I'm certainly not justifying doing projects like that, but I'm just saying that there's a really critical piece there of what you said, that research is going to stop there. And there needs to be more holistic projects developed that have the research and implementation side to it. Donors need to be made to understand that we can't just abandon communities at the research side of things. We have to be able to follow through and build that trust, because then you can go back and collect data later because you've actually made an impact to that community, something tangible that they can actually feel, and you've bought the trust that way through action, not just doing, we've come in and we've collected all the information. But I think right now there's a really big problem with how donors provide funding. It is very siloed. And so if it's, it's a public health research project or it's a community engagement research project, it's in a little box and you have no funding to continue that forward. So again, not justifying it, but just pointing that out as a really important problem, that even if as organizations, we have great intentions of being crossing disciplines, having conversations at all different levels, we may be really limited in what we're able to actually then put out.
So very quickly before we move on, there was a question asked by Erica Garcia in the audience as a quick follow-up, like, are there any examples of proper community engagement where all community members' voices are heard and ideas considered?
So there's East Harlem Health, I'm trying to remember the EHCHC. Cynthia, do you know what it actually is?
East Harlem Health Committee?
Yes, that's
East Harlem Health Committee.
Yeah, so a lot of our students, a lot of representatives from Mount Sinai actually sit with people who represent different organizations in East Harlem. But I would say that, I think that it's really to sort of talk about problems, but and then bring it back to your organization. But in terms of implementing things on a sort of a grander scale, I think, some of that cross collaboration doesn't actually happen. Sort of like listen to the community issues but then bring it back to your organization and sort of do something about it on a siloed way. At least that's been my impression. And I feel like, certainly, again, I'm taking ownership for this. I think we need to do a better job sort of talking about how we network, or as a network, actually address these issues on a sort of a more cohesive level, and take maybe some of that research, for instance, and take it, I digest it and then put it into action. But also, you know, so anyway, that's one forum.
I'll also, so we, Archive Global, is creating, we're about to launch the Health Through Housing Coalition, which we're hoping is just going to be a platform to allow people to really start networking and having some of these cross-disciplinary conversations. But in this discussion, I'm realizing that we actually probably may need to lead people down the correct path a little bit more than just hope that they'll have the right conversations, and maybe some sort of more clear outline about working across disciplines is important. I mean, we are providing on that particular platform like a glossary of terms, because one of the huge problems is we actually don't speak the same language across disciplines. And so we're trying to combat some of these issues that are preventing people from being able to do cross-disciplinary work. But I think that people feel really paralyzed. They don't, you know, you don't even have like the necessary, I meet public health people all the time that's like, I don't even know an architect, you know, let alone an architect who's interested in my context of a small village in Kenya that has problems with like chiggers, you know. So they're just, they don't even know what questions to ask. They don't even know how to engage. And so therefore fusing a project together feels like a really big task. But so we're really hoping to address some of this from a really broad perspective and allow people to start networking. If it's at the micro scale of like East Harlem, where you really want to just discuss that internally, or if you want to like look at a more global scale and start to look at case studies from other contexts that are useful to you. So hopefully that will be out in the next couple of weeks, and if people become members and we can start kind of connecting with each other. And we're also hoping to really get feedback from people, because we never think we're done learning. We always need to be listening, integrating, and iteratively like doing again. And I think that's a very design specific thing.
One of the things that I'm just thinking about as we're having this conversation is like the fact that all of us have the ability to ask, what does a community want, or what might I want? Like those are things that so many people don't have the confidence or self-esteem to even think that they are able to ask. I was in a mold and conversation last week or the week before, and in the chat, someone even asked if it was okay to fix the mold in their apartment twice if it hadn't gone away the first time. So it's like we're talking about, the words built environment are so jargony, right, that even my own board of directors is like, well, I don't know what that means, okay? And this is only one aspect of public health, right? It's not even the bigger picture of design, or planning, or, you know, all the factors that go into that. And I think, like, if we're going to have more interaction with community members, breaking down not only the language, but also having some type of training so that people can even feel that they have the capacity to share their own thoughts, or to ask for what it is that they need, or like the idea of banding together with many people when you yourself do not feel that you deserve in your home a healthy place to live. Like, it's like there's not enough room on this screen to show how far apart those concepts are. And so I think that needs to be taken into consideration, that, you know, from a very early age, youth are taught that they don't matter, that they are not significant, that violence on violence of youth on youth in our community is not a newsworthy item, okay? That it's not newsworthy until the whole country is screaming and yelling and shouting. And even then, the main thing people are talking about is cops on community. They're not even really talking about youth on youth, or a community member on community member, in the way that so many people are calling for a need in the community for a discussion. So I just want to bring it back to what we're seeing on the ground, which is in our classes. I didn't realize that I could have that kind of conversation with you. I didn't realize that I could be a leader. I thought that I, as a Black woman, could not become anything. That's what I was told. These are the things people are saying to me, and I'm not the person they feel most comfortable with at the organization, because I'm not their direct teacher, right? That's the person they're going to share the deepest thing with. But if we don't actually support groups, even like the program Cynthia's running, okay, we're on the ground with these youth, giving them skills and confidence, then there's no way that they're going to feel like they can be in a larger discussion of power, because that's what this is about. And if you've already gotten to planning school, you sense that you have some power to change a city or change something. But that's not where these kids are. So I just want to kind of like, I don't know what the word is, but bring it back to what we're seeing on the ground.
Mac, one of the things that I think, just as a provider also that I find is that we're supposed to ask all these questions. We do. We ask all these questions. We see these things. But I think because we don't have that cross-disciplinary sort of contact, we sort of, physicians, nurses, nurse practitioners, we don't know who to go to. And so to have these, this ability to sort of talk across disciplines, that sort of have a network of people that you can sort of access that isn't just NYCHA, right, is really, I think, helpful for us to know in healthcare, because so much of this actually comes out in a healthcare interaction, right? Whether it's in an office-based setting or in, this is like where I confront a lot of these things. And then, you hear about them, you see these problems, and you think, I don't know what to do. Like, I feel paralyzed. And you'll make the phone calls and you'll hit a wall, and you'll make the phone calls and hit a wall. And so, and as a result, I think a lot of us in healthcare are sort of trained to sort of throw up our hands and say, I don't know what to do. I think that's one of the problems with like having the ability to sort of be privy to these conversations, is sort of like, well, what next?
Mm-hmm. So unfortunately, we are actually at the end of our session. It feels really short, and there's still so much discussion. I really hope this is just a beginning of a very fruitful collaboration. I would just like to thank Sarah, Cynthia, Mac, and Yaz for taking the time to have this discussion with us. And as you said before, please feel free to contact us if you have any further questions, and we'll make sure we direct your questions properly. So thank you very much. And thank you to the audience for attending, and please enjoy the rest of the conference. Thank you.
Thanks, everyone.
Bye, everyone.
Thank you.
Yeah.
Bye.
Oh.